Good day. For this video, we will tackle the radiation protection in computed tomography scanning. Given its crucial function in diagnostic radiology, computed tomography requires special attention. According to the United Nations Scientific Committee on the Effects of Atomic Radiation, CT, which accounts for only 6% of diagnostic medical X-ray examinations in healthcare level 1 countries, contributes a substantial 4% of total population radiation dose. Technological advancements and the expanding scope of CT examinations globally have increased the risk of radiation exposure. Technological developments and global expansion of CT examinations have increased the frequency and variety of these procedures, resulting in significant population radiation impact. Dating back to 1972, the first commercially available CT scan equipment by Godfrey Hansfield was created, and in 1973, the United States had installed the first CT scanners of their own. By 1975, the first whole-body scanner was introduced. 1979 was the time that Godfrey Hansfield and Dr. Alan Kermack, the co-inventor of the first CT scanner, received a Nobel Prize in Physiology and Medicine. By 1998, the initial 4-slice MD CT scanner was introduced, and in 2002, the first MSCT scanners providing 16 slices were introduced. How much radiation is generated during a CT scan? A CT scan typically exposes an individual to approximately 1 to 10 millisievert of ionizing radiation. To contextualize, a person naturally receives about 3 millisievert annually from radioactive materials in their environment. Recognizing the importance of minimizing unnecessary radiation exposure, professional radiographers employ measures to keep radiation levels at a minimum during CT scan. Utilizing X-ray detectors and beam filters can effectively reduce radiation doses in CT scans. Moreover, tailoring each CT scan to the specific size and weight of the patient or the targeted body part further enhances safety. While CT scans are generally safe for patients undergoing occasional procedures, it is incumbent upon radiologists and healthcare professionals to safeguard themselves against excessive exposures to high levels of radiation. Further information will be discussed in order to mitigate potential hazards.
Now I am going to discuss the methods to reduce radiation exposure and enhance protection. Number 1. Justification and optimization of protection in CT. The principles of radiation protection, as outlined by the International Commission on Radiological Protection, encompass justification, optimization of protection, and dose limitation. Justifications plays a pivotal role in examinations involving ionizing radiation, such as CT scans, serving as a crucial tool to avoid unnecessary exposure. There is a widely held belief that unjustified exposure occur frequently in both developing and industrialized countries. Therefore, the responsibility for justifying an examination in individual cases lies with the referring physician, who should seek the advice of a radiologist for alternative examinations that can provide necessary information with lower radiation exposure. Second, minimize time spent in areas with elevated radiation levels. The level of radiation protection designated by a radiation protection advisor for a specific area considers the duration individuals will spend within it. Limiting your time in controlled areas decreases your radiation dose and reduces the risk of adverse effects associated with radiation exposure. Prioritizing efficiency and minimizing unnecessary exposure time are key aspects of ensuring safety. Third is maximize distance from the source of radiation. Similar to a light source, The intensity of radiation weakens as you move farther away from it. Maintaining a maximum distance from the radiation source is crucial for minimizing your radiation dose, while certain treatments or room constraints may limit your control over distance. Safety protocols account for these factors to ensure your well-being during occupancy. Fourth, use shielding for radiation sources. Enhanced radiation protection measures are implemented not only through the inherent shielding of the X-ray unit assembly but also through targeted protection for specific patient organs situated within or in close proximity to the primary X-ray beam. To further safeguard sensitive areas such as gonads, breast, thyroid, and eyes, specialized leaded impregnated materials are strategically placed over and around these organs. This supplementary shielding significantly mitigates radiation exposure to these critical structures during medical imaging procedures. Studies have reported notable benefits from the application of thyroid and breast shields, demonstrating a substantial reduction in surface dose to the breast and thyroid by approximately 20% to 30%. This underscores the importance of adopting comprehensive shielding strategies to optimize patient safety and minimize radiation risk in medical imaging practices. Fifth is adjusting CT scans parameters. Radiation protection is of utmost importance in CT examinations, especially for young adult females. Various scanning factors impact the radiation dose administered to patients. A key strategy in minimizing exposure is the use of automated exposure control with tube current modulation techniques. AAC dynamically adjusts the radiation dose based on the patient's attenuation, striking a careful balance between the dose reduction and maintaining high-quality diagnostic images.
That is why optimizing CT scan parameters is a delicate balance. While adjusting parameters can reduce radiation exposure, there is a trade-off with image quality. The key parameters under the control of CT operator include the tube voltage or the KVP. This factor influences the energy distribution of the X-ray beam. Variances in tube voltage significantly impact CT dose, image noise, and the contrast. The range of X-ray tube voltage in CT scanning spans from 80 to 140 kV. Elevating the tube voltage increases both radiation dose and average photon energy, diminishing image contrast but reducing noise. While abdominal CTs often thrive at 120 kVp, offering a 20% to 40% dose reduction compared to 140 kVp. Pediatric CTs can achieve sufficient image quality at 80 kVp. Next, we have the tube current or the exposure time. The product of X-ray tube current and scan time, which is referred to as MAS, quantifies the radiation utilized in producing radiographic or CT images. Due to smaller size of pediatric patients, making them inherently easier to penetrate, the CT MAS employed for pediatric scans is typically reduced compared for that adults. Beam collimation and slice. The relationship between beam collimation and slice width in MDCT scanning is closely tied to the detector configuration. Broad X-ray beam widths generally lead to a more dose-efficient examinations, minimizing overbeaming within the detected X-ray beam. However, broader beam widths may restrict the ability to reconstruct very thin sections on MDCT systems with fewer than 16 data channels. In these cases, narrow beam widths became essential for reconstructing thinner slice widths, albeit at the cost of dose efficiency. Therefore, selecting a beam width is a critical consideration aligned with the specific clinical requirements. The MDT scanning. MDCT stands for Multi-Detector Computed Tomography. It is a type of computed tomography imaging that utilizes multiple rows of detectors to acquire a larger volume of data per rotation compared to conventional single-detector CT scanners. Overbeaming. Overbeaming occurs when the X-ray beam extends beyond the active detector area, rendering part of the beam non-contributory to imaging. To enhance the scanner dose efficiency and reduce radiation dose, pre-patient control of X-ray tube focal spot, motion, and beam collimation is imperative. This technique mitigates overbeaming by continuously monitoring the beam's position and adjusting the collimating aperture accordingly. This meticulous approach yields a narrower dose profile, distinguishing it from systems lacking focal spot tracking. Next, we have the filtration. In radiology, X-ray filters play a crucial role in selectively blocking lower energy X-rays that contribute minimally to image quality but contributes to patient radiation dose. Numerous studies in the literature have explored the impact of various filters on dose reduction. According to findings, the implementation of bow-tie or beam shaping filters demonstrates a substantial 50% reduction in radiation dose compared to conventional flat filters. These specialized filters optimized the X-ray beam, enhancing both diagnostic and quality and dose efficiency. Alternatively, the application of software noise reduction filters proves to be a valuable option, particularly in high contrast examinations such as chest CT. These filters contribute to refining image quality while maintaining a focus on minimizing radiation exposure, exemplifying advancements in dose optimization techniques.
Optimizing protection in X-ray computed tomography. Emphasizing the importance of optimization, key parameters includes regular dose surveys for comprehensive audits, adherence to diagnostic reference levels, and the implementation of robust quality assurance protocols. Diagnostic reference levels. A pivotal aspect of optimization involves the comparison of measured radiation doses against established diagnostic reference levels. Defined by the Council of European Union, diagnostic reference levels represent those benchmarks for standard-sized patients or phantoms across various types of equipment during typical examinations. These levels serve as a guideline not to be surpassed in standard procedures, ensuring adherence to good practice in diagnostic and technical performance. For CT and other X-ray procedures, reference dose levels offers a pathway to dose reduction. When routinely exceeded, it prompts a critical examination of examination protocols to better align with optimized quality and safety standards. Quality assurance and quality control. Quality assurance serves as a potent tool for optimizing equipment performance in diagnostic radiology. Defined by the World Health Organization, QA is a comprehensive approach encompassing the entire diagnostic process, aiming for consistent production of high-quality diagnostic information while minimizing exposure to patients and personnel. According to quality control within diagnostic procedure involves monitoring, evaluation, and maintenance. In the realm of imaging equipment quality control, three distinct categories are emphasized. Number 1. Acceptance test. This is conducted post-installation of new equipment or major modifications. These tests validate supplier specification and ensure compliance with general requirements. Number 2. Status test. Similar to acceptance test but applied to existing installations. Status test reaffirms the adherence to specifications and general requirements. Number 3. Constancy test. Focus on the straightforward measurements of a limited set of relevant parameters. These tests verify the ongoing proper functioning of the equipment, ensuring that no significant changes have occurred. This meticulous approach to QC not only upholds the highest standard in diagnostic radiology but also fosters a commitment to continuous monitoring, evaluation, and maintenance for optimal performance.
And now, we're going to discuss the 10 pearls of radiation protection for patients in computed tomography. So first, perform scan only if it is indicated. So it is estimated that a significant number of imaging examinations are unnecessary. So consultation between the referring physician and the radiologist is recommended. So in here, we could possibly correlate the justification principle when it says here that physician's request is needed for merit is greater than risk. Number 2 is encourage use of alternative non-ionizing imaging such as MIR and ultrasound when appropriate, especially in younger patients. So using MIR and ultrasound when appropriate is another way of protecting patients, especially the younger ones, because their cells are 2 to 10 times more sensitive than the adults. Using CT as a mode of modality may greatly harm them than the benefits that they will get. Number 3, always check if patient may be pregnant. Use special signs and informative material notifying patients that they must disclose any possibility of pregnancy. Of course, we should always make sure that our female patients is non-pregnant, because if ever, CT emits great amount of radiation that will affect both the mother and the baby. Number 4, high quality or crisp images may look nice but they impart higher radiation dose to patients. Start using images with some noise without loss of diagnostic information. So we have here the 12.6 milligray versus the 4.2 milligray images, in which both are diagnostically acceptable, but for patient safety, 4.2 milligray is much preferable. Number 5, use indication-specific CT protocols for each body region. For example, for lung nodule, follow-up, or kidney stones. Diagnostic images can be obtained at 50 to 75% lower radiation dose compared to routine or general use protocols. Number 6, multiple pass or phase CT should not be performed routinely. Multiple phase CT can increase the dose by as much as 2 to 3 folds over single phase CT. Number 7, adjust exposure parameters according to patient and body part. Number 8, know your equipment. Learn how to adjust the parameters of the automatic exposure control or AEC system to fine-tune radiation dose for different clinical indications and body regions. Most body CT examinations should be performed with use of AEC system. Number 9, good technique, such as lower KVP and MAS, higher pitch, restrict scan length to what is necessary, and always center the area of interest in isocenter of country. All CT protocols should state the start and end location for different clinical indications. Thin slices only when necessary. So we have here examination and reference levels. CT head, we have 75 milligray. In CT adult abdomen, 25 milligray. CT adult chest, 21 milligray. CT pediatric abdomen for 5-year-old, we have 20 milligray. CT pediatric head for 5-year-old, 34 milligray. And last but not the least, finally we have the number 10. Pay attention to radiation dose values and compare with diagnostic reference levels. Be aware of CT dose metrics and recommended dose levels for different body regions. And there you have the 10 pearls of radiation protection in CT scan.
As we conclude this insightful journey into radiation protection and CT scanning, it is clear that safeguarding both patients and operators is paramount. From optimizing imaging parameters for patient safety to implementing strategic measures to shield operators from excessive exposure, our commitment as future radiologic technologists should remain unwavering to comprehensive radiation protection. Thank you for joining us on this important talk where the health of both patients and healthcare workers are prioritized.